Hi, everyone. Thank you so much for joining us today. We've been looking forward to this family planning consultation for quite some time today. Sorry, for the past few months. I'm Sarah Rich. I'm an Associate Director for Sexual and Reproductive Health at the Women's Refugee Commission, and I warmly welcome all of you to join us today. The Women's Refugee Commission is a research and advocacy organization that's dedicated to improving the lives and protecting the rights of women, children, and youth who are affected by conflict and crisis. And we are hosting this webinar today in conjunction with the Interagency Working Group on Reproductive Health and Crises and Family Planning 2020. So many thanks to both the IWAG and the FP 2020 for your support and for joining us today in hosting this consultation. Today, we're focused on shaping the new COVID-19 reality, creating evidence-based solutions to sustain family planning in humanitarian settings and across the humanitarian development nexus. So I'll just give some brief introductory remarks, and then we will go straight into the content. Next slide, please. So we have two objectives for today. The first is really to share findings from the Women's Refugee Commission's 2-year study of family planning in humanitarian settings and across the nexus. So we'll be sharing findings from across this mixed methods research that we've done, much of which was completed before COVID, but which also included a series of key informant interviews conducted during COVID to understand some impacts of COVID. Then we will be breaking into small groups for the interactive portion of the webinar or of the consultation. And in those small groups, we'll be agreeing on recommendations in the key gap areas that have been identified to improve access to family planning in humanitarian settings and across the nexus. Next slide, please. Before we start, I'd like to take a minute to honor our colleague and our friend, Jen Schlecht, who passed away about a year ago now. She fearlessly led efforts to ensure that women and girls affected by crises can access contraception. She was a tireless advocate for women and girls in humanitarian settings. She specifically contributed to integrating the prevention of unintended pregnancy as a core objective in the minimum initial service package for sexual and reproductive health, which is the set of objectives and activities that are meant to be implemented at the beginning of every crisis. So this helps ensure that access to contraception is a standard in every humanitarian crisis. Much of the work that we're doing today builds on the incredible work that Jen did over several years of carefully constructed advocacy and research. So we really wanted to acknowledge the role that she's played in laying the groundwork for all of the work that we have done today, that we're sharing today. Next slide. Here's a quick rundown of the agenda. We'll start just with these brief opening remarks from me. Then we'll move into a presentation of findings from Lily Jacoby from the Women's Refugee Commission. Then we will have a half an hour to do some discussion of the findings. We'll start with remarks from two panel discussants, Gitari Indirangu and Abdikani Hirsi Shire, who will share their thoughts on how the findings resonate with their own experiences in the field in humanitarian settings. Then we'll have some time for questions and answers. Then from there, we'll move into breakout groups to develop 2 to 3 recommendations each based on identified gaps. And those groups will be thematically based. And if you have not yet signed up for a group, please click the link that has been pasted into the chat box, and it will be also broadcast on a coming slide. Then finally, we'll wrap up. We'll share back all of the recommendations that each group has developed and provide a little bit of space for discussion on those recommendations that have been developed in the groups. Next slide. So here's the link for the groups. If you haven't yet selected a small group, please go ahead and do that now. A few of the groups are already full. If you don't select a group, we will assign you to any group that is on the smaller side, and you'll be kind of selected randomly into those groups. So if you do want to have a chance to select your group, please go ahead and navigate to that link and tell us what you'd like to discuss today. With that, I am going to hand it over to Lily Jacoby, who's an advisor for sexual and reproductive health at the Women's Refugee Commission, and who's played really a central role in conducting much of the research that will be shared today. Thanks so much, and handing over to Lily now.
Hi, everyone. Again, my name is Lily Jacoby, and I'm a program advisor on sexual and reproductive health and research with the Women's Refugee Commission. And I'll go ahead and hop right into presenting a global snapshot of contraceptive services across crisis-affected settings. Access to contraception is a human right and saves lives. However, we know that access to contraception continues to be a gap in humanitarian settings. Accordingly, the Women's Refugee Commission embarked on a landscaping assessment to improve knowledge on the state of contraceptive services in humanitarian settings, assess progress and challenges to the successful implementation of contraceptive service delivery in humanitarian settings, and identify key recommendations to accelerate access to contraception for crisis-affected populations across the humanitarian development nexus. The assessment was mixed methods and includes literature review, global coverage survey of implementing partners, key informant interviews, and case studies in 3 humanitarian settings. Notably, these components of the landscaping assessment were conducted prior to the onset of COVID-19. We know that the pandemic has likely triggered significant shifts in contraceptive service delivery, accessibility, and availability across settings. WRC conducted a series of key informant interviews with diverse stakeholders to document the impact of COVID-19 on contraceptive service delivery, innovations to ensure that contraceptive services remain available and accessible, and facilitators and barriers to contraceptive and SRH services in COVID-19 preparedness and response across the humanitarian development nexus. Before presenting findings, I'll provide a brief overview of methods. The literature review assessed the publicly available evidence base on contraceptive service delivery in humanitarian settings. Researchers searched in peer-reviewed journals and gray literature for quantitative and qualitative data on contraceptive services in humanitarian settings, published between 2010 and 2019. For the second component of the landscaping assessment, we conducted a global coverage survey, concluding data collection in spring of 2019 to capture a snapshot of the state of contraceptive service delivery across humanitarian settings. 7 international NGOs, 12 national or regional NGOs, 1 UN agency, and 1 UN agency participated, representing 84 programs across 42 countries and territories. For the key informant interviews, we wanted to learn more about what works to support contraceptive programming in transition periods across the preparedness to relief to recovery continuum, including challenges and strategies to successfully scale and transition programs and to improve collaboration across the humanitarian development nexus. We conducted 14 interviews with 17 informants, including field and headquarters staff, and including respondents from development organizations and development teams and dual function organizations. Finally, we conducted case studies in Cox's Bazar, Bangladesh, Borno State, Nigeria, and in Cyclone Idai affected areas of Mozambique to document the work that stakeholders, including governments, are undertaking to provide contraceptive services to affected populations. In all 3 settings, WRC researchers conducted key informant interviews with government, UN, and partner organizations, facility assessments, including the administration of knowledge and attitudes questionnaires to providers, and focus group discussions with affected communities. Analysis of findings across the assessment revealed a number of key themes, including quality of care, particularly method mix and availability, access to services for adolescents and members of marginalized groups, supplies, data collection and use, preparedness, and localization. And also today we'll be presenting again the findings from the COVID-19 key informant interviews looking at disruptions and innovations. These themes will structure the presentation of findings today and our development of recommendations. So we'll begin with quality of care with a focus on method mix. Key findings reflected the critical importance of and persistent gaps in quality of care and the provision of the full range of contraceptive methods in humanitarian settings. The literature review revealed that long-acting reversible contraceptives, or LARCs, and emergency contraception, or EC, are less available as compared to other methods across diverse settings. Notably, a lack of trained providers is a critical barrier to the provision of LARCs, and providers in multiple settings expressed the need for more training opportunities and skills building opportunities. Providers may also have incorrect or inaccurate information about modern methods, particularly LARCs and EC. EC is a critical component of comprehensive contraceptive services, but dedicated EC products continue to be only intermittently available in humanitarian settings. Where it is available, it's often limited to post-rape care. Moreover, knowledge of EC among affected communities was extremely low across settings, even where knowledge of other methods was relatively good. The coverage survey also reflected differences in the provision of LARCs and EC as compared to other methods. This graph presents the percentage of country programs providing different contraceptive methods in all or some supported service delivery points. Oral contraceptive pills and injectables were available in more than 90% of programs. IUDs and implants were somewhat less available than these short-acting methods, but still widely available in 85% and 75% of programs, respectively. Emergency contraceptives were available in 81% of programs. This graph shows the percentage of country programs providing IUDs, the blue bar, and implants, the red bar, in all or some service delivery points by region. Across these three regions, the provision of IUDs ranged from 62% of programs in East and South Asia and the Pacific to 95% in Sub-Saharan Africa. All three programs in Latin America and the Caribbean provided IUDs and implants, but given the small sample size, we did not include it in the graphs. This graph shows the percentage of country programs providing injectables in the blue bar, oral contraceptive pills, the red bar, condoms, the gray bar, and EC, the green bar, in all or some service delivery points by region. Pills and injectables were widely available across all three regions. The provision of EC ranged from 67% of programs in East and South Asia and the Pacific to 89% of programs in Sub-Saharan Africa. And all three programs in Latin America and the Caribbean provided all of these short-acting methods. Across case studies, LARCs and EC were consistently less available as compared to other methods. And a lack of trained providers and stockouts of supplies and equipment contributed to the lower availability of LARCs. Focus group discussion participants across settings were less familiar with LARCs as compared to short-acting methods and were unfamiliar with or had extremely low knowledge of EC. Moving on now to adolescents and marginalized populations. Data across the assessment clearly shows that adolescents and members of marginalized populations continue to face heightened barriers to contraceptive services in humanitarian settings. The evidence documented in the literature review demonstrates that adolescents in humanitarian settings want and will use SRH information and services, including contraception. However, a 2012 comprehensive mapping of SRH programs serving adolescents in humanitarian settings found very limited availability of adolescent-friendly services. Although there is a growing body of research on the SRH needs of adolescents in humanitarian settings, there is very little evidence on the needs of persons with disabilities, and even less so on programming that can meet those needs successfully. The coverage survey included questions about the accessibility and availability of contraceptive services for adolescents, persons with disabilities, and persons engaged in transactional sex, and LGBTQI and gender nonconforming people. Notably, high percentages of respondents reported that they did not know if contraceptive services were accessible and available for LGBTQI and gender nonconforming persons and persons engaged in transactional sex, reflecting the need for increased data collection and research and programming designed to meet the needs of diverse populations. This graph shows the percentage of respondents reporting that contraceptive services were accessible and available to unmarried adolescent girls, never or sometimes in blue, most of the time or always in orange, or that they did not know in gray. Across all regions, 41% of programs reported that contraceptive services were never or sometimes available, and 41% reported most of the time or always. 68% of respondents in Sub-Saharan Africa reported contraceptive services to be available to unmarried adolescent girls most of the time or always, compared to 13% of respondents in the Middle East and North Africa, and 42% in East and South Asia and the Pacific. In Latin America and the Caribbean, 1 program reported never or sometimes, and 2 reported most of the time or always. This graph shows the percentage of respondents reporting that contraceptive services were accessible and available to persons with disabilities. Notably, across regions, higher percentages reported not knowing about the accessibility and availability of contraceptive services for persons with disabilities as compared to unmarried adolescent girls. 68% in sub-Saharan Africa, 35% in the Middle East and North Africa, 33% in East and South Asia and the Pacific, and 1 program in Latin America and the Caribbean. However, also across regions, higher percentages reported contraceptive services to be accessible and available to persons with disabilities most of the time or always, ranging from 57% in the Middle East and North Africa to 27% in sub-Saharan Africa. In Latin America and the Caribbean, 1 program reported never or sometimes, and 2 programs reported most of the time or always. Across case studies, adolescents expressed very strong interest in and a need for access to contraceptive and SRH services. However, adolescents across settings consistently faced heightened barriers to accessing services, particularly for unmarried girls, including higher levels of stigma and negative attitudes from both community members and health providers, and oppositions or barriers from parents or spouses. Across settings, FGD participants reported that persons with disabilities faced greater barriers when accessing contraceptive services, including due to distance, a lack of transportation, and inaccessible facilities. Moving on now to supplies. Successful contraceptive service delivery depends on the availability of supplies, but data indicates that challenges with supply chain management and supplies availability persist across humanitarian settings. The literature review reveals documented gaps in the availability of contraceptive supplies across settings. Stockouts of different contraceptive methods and of the interagency emergency reproductive health kits were documented or reported in multiple settings. Additionally, poor data collection on supply chains and stocks impedes the ability of programs to forecast appropriately and procure supplies on a regular and sustainable basis, and supplies-related issues are exacerbated where products are not registered in country, as is sometimes the case with emergency contraceptive pills or ECPs. The Global Coverage Survey also collected data on supplies. This graph shows the percentage of country programs reporting a stockout of the method in the 3 months preceding survey submission. Stockouts appear to pose challenges across programs and methods, ranging from 23% of country programs reporting stockouts of OCPs to 13% for implants and injectables. However, it is important to note that many submissions indicated that they did not know about the occurrence of stockouts, ranging from 7% for condoms to 21% for IUDs and 25% for EC. It is therefore possible that the occurrence of stockouts was higher than is reflected in the data collected. This graph shows the percentages of programs procuring methods through different sources in acute settings, including UNFPA or another UN agency, the blue bar, the government, the orange bar, a domestic private source, the gray bar, or an international private source, the yellow bar. In acute emergency settings, across all methods, a plurality of programs reported procurement of contraceptive commodities from UNFPA or other UN agencies, ranging from 41% for implants to 50% for OCPs and condoms. Private sources, both domestic and international, were also used across methods. Programs reported procuring from governments in acute settings at the lowest rates across all methods, ranging from 15% for EC to 21% for implants and OCPs. In post-acute settings, nearly half of respondents reported procurement of all methods except condoms from UNFPA and UN agencies. A greater proportion of respondents reported procurement of methods from the government than in acute settings, ranging from 22% for condoms to 41% for OCPs, while a smaller proportion of respondents reported procuring methods from the private sector, ranging from 11% for implants to 22% for OCPs and injectables, when domestic and international private sources are combined. Programs also reported the common sources of delays in their supply chain. This graph presents common sources of delays by region, including financing in dark blue, stockouts at the supplier or manufacturer level in orange, delays in shipping to country in gray, registration or waiver issues in yellow, customs-related delays in country, light blue, and transportation delays in country in green. Programs could select multiple sources of delays. Notably, we did not observe substantial differences in sources of delays between acute and post-acute settings. In East and South Asia and the Pacific, the most frequently reported cause of delay was transportation delays in country, followed by delays related to financing at 33%, and transportation delays in country accounted for 48%. In the Middle East and North Africa, the most frequently reported delay were delays in shipping products to the country at 40%, followed by challenges due to transportation delays in country at 35%, and delays due to financing at 30%. Among programs in sub-Saharan Africa, the most frequently reported challenge was due to transportation delays in country at 51%, followed by stockouts at the supplier or manufacturer level at 43%. The case studies also collected data on the availability of contraceptive commodities and supply chain management. Notably, WRC documented stockouts of contraceptive commodities during health facility assessments in all settings. In Borno State, Nigeria, and Mozambique, respondents reported challenges related to supply chain management and stockouts that negatively impacted the availability of contraceptive services. Challenges in these settings included last mile delivery, storage conditions, wastage, and quantification. Interagency emergency reproductive health kits were in use across settings and were a primary source of contraceptive commodities in both Cox's Bazar and Borno State at the time of data collection. Moving on now to data collection and use. Findings across the landscaping assessment demonstrated the importance of data collection and use to ensure successful contraceptive service delivery in humanitarian settings. We'll first present information on data collection and use across case study sites. In Cox's Bazar, many partners were providing services in the camps, and while this was instrumental in ensuring that services were widely available, it did pose some challenges for data collection, reporting, and use. Respondents did report that data collection was improving, but not all partners reported data each month. Respondents also noted that providers from multiple organizations often worked out of shared facilities, which could lead to double counting, and that organizations were working to standardize indicators and definitions, but inconsistent definitions had complicated efforts to review and compare data. Nonetheless, respondents confirmed that data from across partners were presented and reviewed at SRH coordination meetings on a regular basis. In Borno State, Nigeria, mechanisms were in place to collect data from implementing partners, but challenges included over-reporting and late, incomplete, or missing data. Most organizations reported reviewing data on a regular basis, and notably, multiple program managers reported having quarterly data review meetings that included government health agencies, community members, providers, and NGO staff. However, health facility assessments indicated limited displays of data, limited capacity to describe trends in contraceptive service delivery data, and incomplete registers. In Mozambique, the cyclone destroyed many paper-based registers and client cards, disrupting data collection and reporting at the outset of the emergency. Ministry respondents reported challenges with late reporting and variable data quality, and several respondents reported that a change in the definition of a new user of family planning and a subsequent lack of clarity between partners had led to challenges with data accuracy. Additionally, national systems for collecting contraceptive service delivery data were fragmented across cadres, leading to potentially incomplete data. Respondents did report that data was shared in coordination meetings at the national and subnational levels over the course of the response, and used to inform prioritization and resource allocation during the response. While health facility assessments indicated limited data visualizations on display, providers were generally able to describe actions taken as a result of data reviews. Data collection and use, again, is essential for strong supply chains and effective service delivery that meets the needs of the women, girls, and communities that it serves. Publication of data and a strong evidence base supports partners to implement and scale effective program models. However, the literature review revealed a lack of robust data on effective interventions. There is, however, programmatic evidence supporting multi-pronged contraceptive services programs designed to improve method mix, provider capacity, commodity availability and security, and monitoring and evaluation. There's also evidence for community-based service delivery via mobile health units and community health workers, the provision of contraception and post-abortion care, and the use of subsidies and voucher programs. We'll now move on to preparedness. Key findings and lessons learned across the landscaping assessment, particularly in the case studies and key informant interviews, consistently highlighted the importance of preparedness for efficient and effective SRH humanitarian response, largely by demonstrating that it is still a persistent gap. In the key informant interviews, respondents emphasized that the strength of a country's health system, its resources, and its existing national capacity, including preparedness planning, have a significant impact on the success of a humanitarian response and transitions to recovery. Respondents also discussed organizational preparedness activities, including supply chain strengthening providers' clinical skills, and building staff capacity to advocate to stakeholders to ensure that SRH and contraception were addressed in an emergency response. Respondents also reported that partnering with local stakeholders and investing in local capacity supported sustainable, resilient programs that were better able to absorb shocks and respond to crises. Finally, humanitarian and development respondents felt that the preparedness phase of the continuum offers a critical windows for partners to coordinate and work together. In Cox's Bazaar, effective preparedness strategies and enabling factors that supported contraceptive service delivery and uptake included that UNFPA Bangladesh had consistent funding before and during the emergency, which contributed to pre-positioning of contraceptive supplies, availability of supplies from the onset of the emergency, and the presence of a dedicated SRH coordination team. UNFPA again reported having supplies early in the emergency, in part because the kits were pre-positioned in Bangladesh as part of preparedness for cyclone season. UNFPA provided early support to organizations that were already present and registered in Bangladesh, and there is a strong NGO sector in Bangladesh, which ensured availability of contraceptive services early in the response. In Mozambique, multiple respondents noted a general lack of emergency preparedness, including for health and SRH prior to the cyclone. This posed challenges over the course of the response. Respondents reported that awareness of the MISP was generally low among government staff and providers at the outset of the response. UNFPA provided and led distribution of the interagency emergency reproductive health kits and provided training on how to use them, but respondents reported challenges due to a lack of familiarity with kit management. More broadly, lack of capacity for supply chain management prior to the cyclone exacerbated challenges with the availability of contraceptive supplies and therefore services during the response. Multiple respondents over the course of the case study explicitly expressed the need and the desire for more training on emergency preparedness, including for SRH. However, respondents did report that the presence of family planning focal points at the district level prior to the cyclone supported the inclusion of contraceptive service delivery in the humanitarian response. Moving now to localization. Key findings demonstrate the value and importance of investing in local actors to lead humanitarian SRH responses. Over the course of the key informant interviews, respondents consistently reported that within programs, conducting capacity building and system strengthening activities, including clinical training and supervision and supply chain strengthening, builds local ownership, ensuring programs are sustainable and resilient. Multiple respondents emphasized the importance of localization for immediate SRH humanitarian responses at the outset of an emergency. As one respondent noted, these organizations are the first responders and will remain on the ground after international organizations have departed. Respondents perceived localization to support efficient and sustainable humanitarian responses across the board and collaboration across the nexus. However, respondents acknowledged that localization efforts are hampered by the current humanitarian funding apparatus, in which humanitarian funding largely flows to and through international organizations. Respondents emphasized the importance of investing in national and local organizations and ensuring that they are equipped to manage larger scale programs. We've included the following quotation from a key informant, highlighting the unparalleled but too often overlooked role played by responders at the community level. This is something we overlook as implementing partners or international organizations. We think that the first response to a humanitarian crisis is what we provide, what we bring. No, when people are fleeing, when people have been displaced, the first response is not coming from international organizations, not even from the government. The first response is coming from local communities, coming from local organizations. WRC partnered with one such organization to conduct the case study in Mozambique, MODEFA, the IPPF member association in country. MODEFA played an important role in SRH response in Cyclone Idai, including delivering contraceptive services. They were recruited to coordinate misimplementation and conducted outreach and sensitization on available services to affected communities. MODEFA has a long history of providing SRH services in Mozambique, and they were able to leverage their existing services, networks of community health workers, and strong relationships with communities to launch activities immediately following the response. MODEFA reported that they were the only national NGO that participated in the SRH working group, and that they played a critical role in linking communities with humanitarian actors. However, MODEFA reported that securing funding to support and sustain their participation in the response was a challenge and also posed a key barrier to the participation of other national NGOs. MODEFA is committed to building capacity for emergency response among their staff, planning to continue engaging in humanitarian response moving forward, and plans to develop a training platform to support other national NGOs to participate in future responses, including by providing training on the MISP for SRH. Now we're going to shift gears a little bit, and I'll present key findings from the key informant interviews that WRC conducted following the onset of the COVID-19 pandemic. WRC conducted 29 key informant interviews with representatives of 1 UN agency, 3 ministries of health, 11 international NGOs, and 5 national NGOs in humanitarian, fragile, and development settings across regions. The interviews explored disruptions and adaptations in contraceptive service delivery and programming, barriers for communities, including adolescents and marginalized populations, facilitators and barriers to contraceptive services for SRH, and SRH in COVID-19 preparedness and response, and the impact of COVID-19 on the funding environment for contraceptive services and SRH in humanitarian and development settings. The nature of disruptions and challenges were highly consistent across diverse humanitarian and development settings, although the presence or impact of a disruption was highly contextual. The most commonly cited challenges and disruptions included movement restrictions, including lockdowns, and a lack of personal protective equipment, or PPE. Respondents also discussed challenges due to facilities and staff being diverted to COVID-19 treatment. Respondents reported that particularly in the earlier phases of the pandemic, the availability of LARCs was especially negatively impacted due to providers potentially needing to use more PPE for insertion and the inability to provide LARCs via telemedicine. In addition to service delivery, many respondents reported that provider trainings and community sensitization activities were severely disrupted by movement restrictions and social distancing measures. Critically, respondents also discussed challenges due to providers being quarantined and providers becoming ill or even dying as a result of COVID-19. Respondents reported that movement restrictions also had significant impacts on SRH supply chains at every level, from manufacturing at the global level to getting products in country to last mile delivery. These disruptions drove up transportation and shipping costs. Additionally, several respondents reported a decreased availability of the interagency emergency reproductive health kits. Movement restrictions did reportedly impact data collection and reporting for some, although not all, respondents. Additionally, some respondents reported that a lack of access to technology and internet connectivity impeded their ability to adapt data collection and reporting. We also explored the barriers that COVID-19 posed for communities to access contraceptive commodities and services. Key barriers included fear of COVID-19 in visiting facilities, movement restrictions, and associated increases in transportation costs, which was compounded by loss of livelihoods due to the economic impact of COVID-19. Loss of livelihoods also posed barrier in contexts where there is a cost for receiving services. Respondents also described clients arriving to facilities only to find that they were closed or stocked out of their method. Respondents also across settings also discussed acute concerns about adolescents being out of school and facing risks of increased gender-based violence, including child early and forced marriage and unintended pregnancy. We'll now consider adaptations and innovations. Technology, including telemedicine, played an important role for organizations to adapt their activities and continue delivering services. But respondents emphasized that the feasibility and suitability of telemedicine is highly variable across settings, depending on access to technology. Frequently cited adaptations and innovations included the use of calling and WhatsApp to provide counseling and follow-up and to direct clients where to go to obtain their methods, reporting data electronically, including via WhatsApp, and using Zoom for provider training and WhatsApp groups to provide support to providers. Community-based service and information delivery also played a role in ensuring that services remained available, although respondents in some settings reported stopping community-based distribution due to concerns about the spread of COVID-19. Other respondents reported reinforcing or instituting community-based mechanisms to deliver commodities, share information on COVID-19 prevention and available services, and encourage communities to continue seeking services. Respondents also discussed distributing multi-month supplies for oral contraceptive pills, DMPASC, and condoms, task shifting and sharing, including shifting delivery of some contraceptives to pharmacies and dispensaries, and supporting self-administration of DMPASC. Multiple respondents across settings also discussed the importance of integrating the delivery of contraceptive and SRH information and services with COVID-19 messaging and other priority health services to maximize resources and minimize communities' contact with the health system. We also explored broader factors affecting contraceptive access and availability amidst COVID-19, including differences in disruptions and adaptations between humanitarian, fragile, and development settings, preparedness, and prioritization of contraceptive and SRH services during COVID-19 response. Notably, respondents differed in their perception of the extent to which humanitarian and development actors were more or less equipped to respond to COVID-19 and ensure the continuity of contraceptive services. Multiple respondents perceived humanitarian actors and programs to be more responsive and agile for COVID-19 adaptations. Additionally, many respondents working in fragile and humanitarian settings reported using the MISP for SRH to inform prioritization of SRH service delivery. Conversely, some respondents felt that development programs and actors were better resourced and thus better able to absorb shocks. This divergence may be reflective of the previously stated finding that the extent to which settings and programs were impacted by COVID-19 was highly variable and context specific. Humanitarian and development respondents reported that preparedness, or in many cases a lack thereof, played a role in SRH response for COVID-19. Humanitarian and development respondents largely reported that both governments and organizations did not have health and SRH preparedness plans prior to the pandemic, and indicated that this lack of preparedness impeded actors' ability to respond quickly. Notably, several development respondents expressed the perception that development stakeholders still largely do not consider preparedness to be part of their area of working. Respondents acknowledged that existing government and organizational preparedness plans also did not anticipate a global pandemic. However, several respondents perceived that settings with experience responding to Ebola were more prepared and adaptive for COVID-19 response. Respondents reported that preparedness activities conducted prior to the pandemic did support adaptations in response, including training staff and providers on the MISP for SRH and supply chain strengthening activities. With regards to the prioritization of contraceptive and SRH services during COVID-19 response, perceptions varied. Some respondents noted that governments included contraceptive and SRH services as essential services and guidelines, or were receptive to advocacy, while others perceived prioritization to be very low. Advocacy included emphasis on the long-term consequences of increases in unintended pregnancy and lessons learned from the impact of Ebola on maternal mortality and morbidity. Critically, several respondents noted that even where SRH was prioritized, contraception was still neglected, as many do not yet understand that it is in fact a life-saving public health intervention. Finally, multiple respondents reported challenges due to the large volume of guidance documents that were generated, particularly for frontline staff, and emphasized the importance of respecting and really emphasizing expertise of frontline staff in determining and knowing which adaptations will be best suited for their environment. Respondents largely felt that coordination across stakeholders facilitated contraceptive service delivery and SRH response, but some did report challenges associated with shifting to virtual meetings and the sheer volume of high priority demands facing stakeholders, particularly governments at the outset of the pandemic. Respondents felt that strong coordination mechanisms prior to the pandemic supported fast and effective response, and some reported that their organizations leveraged existing relationships to address supplies challenges, including transportation and sharing or loaning of supplies. Existing relationships with ministries also supported the prioritization of contraception and SRH in both humanitarian and development settings. Finally, respondents discussed the impact of COVID-19 on funding to ensure continuity of services. Positively, respondents largely reported that donors allowed flexibility to reallocate funds to ensure service continuity, and the majority reported that their organizations did not have to reallocate funding away from SRH to COVID-19 activities. However, some respondents did report that governments had reallocated funding away from SRH as a result of COVID-19, and several respondents reported incidences in which donors were not able to follow through on planned funding due to COVID-19. Respondents across settings reported that COVID-19 had resulted in increased costs to conduct many activities, and multiple respondents reported seeking additional funding to support service continuity, including to procure PPE. A small number of development respondents did report tapping humanitarian funding streams. Notably, diverse respondents across humanitarian and development settings expressed concern and high levels of uncertainty about SRH funding environments over the coming years as a result of COVID-19. To conclude the interviews, respondents were asked to reflect on lessons learned. Many respondents reflected on the importance of preparedness and localization. Respondents articulated that COVID-19 has underscored the importance of and revealed gaps in preparedness at every level, including organizational preparedness across the humanitarian development nexus. Humanitarian and development respondents recognize that development actors must engage in preparedness, but respondents also noted that they have not historically considered preparedness as being part of their remit. COVID-19 is pushing many to reconsider. Across sectors, movement restrictions have highlighted the essential role that local and national actors play in responding to crises. INGO respondents reported being surprised at how successful they had been in executing many, although not all, of their functions remotely, and felt that this reinforced the importance and feasibility of shifting resources closer to the field. Accordingly, respondents called for changes in the way that organizations work and noted that the design and evaluation of programming should incorporate preparedness and system strengthening activities to build resilience. However, respondents noted that even with many stakeholders across sectors discussing localization at this moment in time, they had not observed corresponding funding shifts. They emphasized that operationalizing localization will depend on donor prioritization and investing. To conclude this presentation, before moving on to discussion, we'll pivot back to look at key themes that have emerged across the components of the landscaping assessment, including in many ways the COVID-19 key informant interviews. Based on our key findings, we have identified the need to meet the clear demand for contraception in humanitarian settings and to address barriers for adolescents and marginalized populations, to improve quality of care, including the availability of large NEC, to improve data collection and use, and build the evidence base on effective contraceptive service delivery programs in humanitarian settings, to strengthen supply chains and improve commodity security, to to ensure diverse stakeholders, including governments and development actors, invest in preparedness for SRH to mitigate the impact of crises, and invest in local stakeholders to ensure efficient, effective SRH response and support sustainable recovery. And that concludes the presentation. Thank you all, and I'll turn it back over to you, Sarah.
Thank you very much, Lily. Thanks for the great presentation. We are going to go into to hear from a few folks who are panel discussants with us today. We have Gitari Indirangu from Pathfinder International on the Momentum IHR team. And we have Abdikani Hersi Shire from Save the Children International Somalia office. So we are going to be asking both of these discussants to comment on the findings and what resonates with them based on their experiences working in humanitarian settings. And we're particularly interested in hearing from them about how they've seen these key themes around adolescence, method mix, supplies, data collection, preparedness, localization, and COVID-19 play out. So I'll turn first to Gitari. We would love to hear your thoughts.
Thank you, Sarah, and thank you, Lily, for such a comprehensive presentation. I think we really enjoy, just hearing the kind of things that we should focus on, especially if you're going to make these humanitarian settings resilient enough to be able, to withstand the shocks and the stresses that come with some of these disruptions. I do see a lot of some of those things really resonating with the kind of work that we are doing and seeing, both from the humanitarian setting, but also at the onset of the ongoing pandemic, really things that remind me that the fact that, the phases of a crisis really, from preparedness. I think it's important for us to be prepared at all times. Because one never knows. I think one of the things we've seen, even with the COVID-19 pandemic, is that the countries that had, high visibility of the family planning program, for example, then having the conversation about continuity of services as essential services was much easier than in contexts where, that program doesn't have as a high visibility as one would wish it could. I think the other thing is also to remember that in humanitarian settings, some of these phases, preparedness, responsiveness, recovery, so sometimes the crisis can get escalated, and so we are pushed backwards rather than moving forward towards resilience. So making sure that at all times we really are on top of things. I think a couple of things really resonate a lot. The fact that it's clearly articulated the issue of adolescent and youth, and in many of these settings, they form a huge proportion of the population, yet access to services for various reasons, both from the demand and supply side, actually act as barriers for them to access these services that they do need a lot. And if you look at perhaps the demand side, there are many things, myths, misconceptions, social and gender norms that prohibit them. For example, in some settings, women and girls cannot make decisions for themselves. They have to rely on somebody else to do that. And so asking ourselves, how can we then work better to be able to strengthen that, sort of work with the communities and bring out some of those issues to the fore and look for solutions jointly. In settings, we've also seen in settings where there's war or other crisis that leads to loss of lives, some of the things they indicate that having large families gives them a sense of belonging. It's like you're replacing the ones who have been lost, but also if you are a displaced person, it also gives you a sense of, some humanity in you, gives you that you feel like you belong somewhere. And so we have to be able to navigate through and working with what the communities do recognize and understand. For example, many of them do value the health of women and children. And so if you come from the approach of healthy timing and spacing of pregnancy, then perhaps you can begin to discuss how do we space, how do we time it so that adolescent girls will not get pregnant until they are much older, of 18 and above, so that then they can be able to be ready for the pregnancy and live and their life after that. I think the other thing that, of course, means also for the adolescent too, and other people who are marginalized. I think you, Lily, did mention people with disabilities who again face this a lot of challenges in accessing care. And so, when you're looking at the health system itself, looking at provider, how do we make sure that we have in place provider behavior change, including value clarification and attitude transformation as necessary, so that they see, because they also come from these communities. And so you can begin navigating and demonstrating to them, of course, with evidence, how if we shifted the way we do things, we can be able to be more impactful. I think at the same time, it's also thinking about GBV and what interventions we need to provide for women and men who have been violated, so that then they can be able to provide comprehensive care. And one of the things that that Lily talked a lot about is the fact that there's a bias towards short-acting methods and more against long-acting reversible contraception and the emergency contraception. And one of the things, of course, we do recognize of course, navigating the issues at the community level with the population itself, the users, the potential users, in terms of myths, misconceptions, misunderstandings, but also at the healthcare system level, is that providers a lot of the time do not have the knowledge and the skills to be able to provide, especially the long-acting reversible contraception, and a lot of the time, especially the AUD. So then we must make very deliberate efforts to make sure we have ongoing, continuous systems that allow them to maintain the knowledge and build the capacity for them to be able to provide the methods. As it relates to commodity security, including those stockouts and all that, I think we must also remember the last mile distribution. Sometimes you may have commodities that are available at the central level, but getting them to get to the last mile becomes a bit of a difficulty, especially in settings where there could be insecurity or roads are impassable. All those things do contribute a lot to making sure that, as you are thinking about it, we are able to look at how we do this, whether it would be kitting and making sure that we have sufficient ways of making sure that the commodities get to the facilities or where they are needed, even to the community level. Lastly, I just want to point out that we cannot overemphasize the value of self-care, and I think Lily has talked a lot about that, whether they are fertility awareness methods, including amenorrhea, but also, and of course, the pills and the condoms, but I think also a little more so with the DMPA subcutaneous, I think making sure that it's available as much as possible to the community level or the user. But I think we know very well the value of long-acting reversible contraception, and in the essence of a crisis or even a pandemic like COVID-19, the fact that it can be used, we can extend the use beyond the labeled duration, and also making sure that the supplies of short-acting methods are given a little more generously than we usually do. Let me stop there, but this is a very exciting conversation. I'm very happy to be here. Over.
Many thanks, Gitari. Those have been really insightful comments, and I think it's great to hear how your experiences do resonate with the research, but also that you've added so much nuance to the way that we've shared the findings. So thank you so much for that. Abdikani, I'd like to now call on you to share your thoughts on how the findings resonate with your experiences.
And thanks very much. It's really great to have you all, and I'm very excited to be part of this conversation. It's really interesting topic, and I really appreciate and say thanks to everyone who organized this, especially Lillian, who actually presented very interesting areas. For me, actually it resonates, and I agree with Gathari. It resonates with our existing, or existing programming here in Somalia. If I go back before we started the farm plan and post-abortion care in Somalia in 2012 as Save the Children, it was quite very sensitive and something it cannot be talked about. And though the general SRH program was very low, but again, the farm planning was again something that have been somehow neglected, and it was quite challenging due to sensitivity, misconceptions, communities, cultural, religious issues. There was a lot of issues or challenges that was around the farm planning services. And we all know that Somalia is one of the highest maternal and newborn mortalities globally. When we come to challenges, actually, as presented by Lillian and as findings in this research, actually we face in day-to-day these challenges, including misconceptions and sensitivity of the topic within the context of Somalia, where people are very, conservative, and it's very hard to discuss some like farm planning and reproductive issues publicly. And initially, I remember sometimes even the farm planning program we was calling PMOC survey, something like that, so that we try to manage the sensitivity of the topic while trying to serve the community, those who in need. Again, in Somalia, one of the issues that was that there was a lot of fragmented, systems and miscoordinations. Though there's a lot of improvement, but there is still something to do with communities. Also, again, it's something, again, it's a challenging issue, and because of the international procurement, the freight cost was very, very expensive, especially in the COVID, in the light of the COVID. So actually, it's again, adolescence is something, was having issue again, especially here in Somalia. Though after 2018, we tried to segregate the data into age. That helped us actually a lot to see who we are reaching. Are we reaching actually adolescents? Because there's a lot of bias in the service delivery points. So we try to segregate data and see, are we reaching actually the adolescents? As we know that there is a lot of the early marriage is common here in Somalia. So after that, after 2018, there was a lot of improvement, because again, in addition to the age segregated data, we also did, focused training on adolescents services. Again, people with disabilities, people with special needs, something like that, and that improved, the awareness and knowledge and skill of the service providers. At least there is some improvement, though there's a lot of things to do with adolescent services. One of the issues we did a focus group discussions, study on barriers and status of the farm planning acceptance within the Somali community. Though the sample size we was just focusing on one region in Puntland, but again, adolescents was mentioning, both girls and boys was mentioning that they really they are very confident to midwives and nurses, but again, they don't feel they don't come to the facilities and request the service they need. In terms of COVID-19, yes, actually, there's a lot of have been mentioned. COVID-19, though in Somalia, there was a lot of, our biggest worry was that there would be a massive, deaths or spread. But the Somali government put a lot of tight measures ahead before the case was identified. That was helped a lot. Again, one of the issues that helped Somali community is that the COVID during the summertime is very hot here in Somalia. That could, though there's no reliable source of research that are saying the weather have some effect, but that again at the time now we are speaking, as we speaking, that numbers and the cases are increasing, and that's the Minister of Health and the supporting NGOs are claiming that the issue because of the hot, the cold weather of the winter. Now as we enter into winter here in Somalia, that could be part, worsening the situation. Yes, of course, COVID-19 affected the service delivery. People was again, worrying to visit facilities because people believe that the facilities are one of the highest, when they can contact the infection. Finally, what I want to say is that yes, there is a lot of things, challenges and recommendations that have been mentioned here actually resonate with Somali context as we face, recurrent, emergencies, including, drought, flooding, COVID-19, a lot of issues of multilateral, humanitarian issues are surrounded here in Somalia. So I think these issues resonate with Somali context, and we face every day. And I really thank to everyone who participated to this. And I think this will be very helpful in regard to improving the service delivery, SRH services, especially to adolescents. And thank you very much for your time, and wish you all the best.
Thank you very much. Also, really enriching comments, particularly in thinking about how these themes play out in settings that face recurring or chronic crises. Thanks so much to both of the discussants. I'm so pleased that we found you. Okay, so now we're going to go into Q&A. And I'm going to go back to the questions that have come out throughout the webinar. And I will pose questions about the research to Lily, and then add in, from my side as well, if needed. And then there are a couple of questions that I think can also be answered by the panelists. So I will pose those questions over to you as well. I'm going to skip the questions that were answered directly in the chat box and just focus on the ones that have not yet been answered. So the first question for Lily is, condom availability seems surprisingly low. Is this representative of availability overall, or availability specifically for family planning, as opposed to availability for HIV services, for example?
We did note in the coverage survey data that we were a bit surprised about the percentages indicating that programs were providing condoms in all or some service delivery points, but I don't know that I can really comment on indications as to what that might suggest about availability in contraceptive service delivery programs as compared to programming that's focused specifically on HIV. I believe Sarah Casey is also on the call, and Sarah Casey led the development of the survey, so she's also welcome to unmute and contribute if, Sarah, you have anything else that you'd like to add to that as well. But
Sarah?
No,
I don't know if you're...
She may not be.
Yep, there we go. Okay, go ahead, Sarah.
Yeah, I mean, I think we did ask about condom availability, and people knew this was a family planning survey, so it was people who focused on the family planning pieces. So it is possible, if condoms were available as part of an HIV program, that they were not counted here. But we didn't get into that level of detail in the survey, so it's unclear how that is.
Thanks, Sarah. Yeah, I mean, I think it at the very least indicates some level of disconnect between condoms and the other methods, because either people weren't sure if condoms were available, they were available elsewhere, they weren't available in the family planning programs, even though we don't have the answer to exactly why. I think the data does indicate some level of disconnect. Okay, the next question that I think actually would be really well answered by the panelists is, in a community where traditional and religious norms bar the use of contraceptives, how can we have a coordinated response to harmonize the use of contraceptives and make it possible within the community in order to allow young girls to get such services? So maybe I'll just ask if Abdikani or Gatari, if either of you would like to comment on that question.
Sure, Sarah. Yeah, it's of course, yes, it is important, of course, as you are working and interacting with communities, also be cognizant of all those the belief systems and religion and whatever else that determines how communities make decisions. And I would also, and I know Abdikani will agree with me, I think a lot of the times religion is used as a barrier because of perhaps lack of sufficient awareness of what religion itself provides for. So that then if you engage with religious leaders, you actually quickly, a lot of the time, you're able to navigate through some of the things, the teachings that are available in the holy books, and you're actually able to get a solution that themselves are embedded within that particular religion. Could be Christianity or Islam, and I think, or any other religion. A lot of the time, you're actually able to look for solutions. But we need to be aware and alert to the fact that religion also has a huge grasp on, a huge grip on the people, and so we cannot be able to ignore that. And a lot of the time is being able to approach them respectfully, look for solutions from within. I think whatever it is that you're doing, we cannot make solutions for them from elsewhere. We have to actually center our solution, our processes within the community or the people that you're serving, the human-centered design, so that then you can be able to look for solutions that they do own and acknowledge, and they can be able to take forward. A lot of the time, of course, is working with the people who make decisions, or opinion leaders, opinion shapers, be they religious or traditional, whatever form of belief system they have, making sure that you identify the people who will drive that. And we do agree, yes, of course, it is an important, but there are solutions for every, and I don't think they prohibit, many of these religions actually do not prohibit, do recognize the value of women and children being healthy. And of course, adolescents fall into that. And so it's then working around them to see how do we navigate that. And when you have solutions, or when you come across problems that relate to adolescent pregnancy, definitely you'll be able to look for solutions together. Over. I'm sure Abdikarim might want to add something. Over.
Thank you so much. I think what you said makes so much sense, especially around centering within communities. Abdikani, please, I see you have your hand raised, so I think that probably means you'd like to comment as well.
Yes, actually, it's really, I agree with Dr. Gathari. It's very, very clear that, yes, initially, that what we faced here in Somalia, the religious was one of, barriers that we're having. So working with religious leaders is one of the best ways to address that. Again, what we did also is that using, messages extracted from the religious perspectives and focusing on religious perspectives, again, worked well. Again, targeting communities and, segregating communities, because people cannot understand at the same channel or the same, language. So segregating communities into religious leaders, communities, those who have some knowledge, or young to adults like that, and focusing, because we know that contextualizing, to contextualize the messages that we send to communities also make a lot of, efforts. Again, one of issues that supports us that community strategy that we developed and focusing at different levels of communities and having messages that are suited to different ages, cultures, beliefs, and like that. I think that will help again in like that issues. Thank you. Over.
Thanks so much. Yeah, thank you very much. I think these are really insightful answers from both of you that that make a lot of sense. Okay, I'm going to go to the next question. The next question, the person says, I wonder what is most predictive of contraceptive continuity in emergencies. My hypothesis is it's the robust baseline of contraceptive availability and uptake, especially LARCs, but curious to hear from the researchers and panelists. So the question is, what do we think is most predictive of contraceptive continuity in emergencies? Lily, I will start with you.
Sure. So I think one thing that really did come out, so if I'm going to tie this specifically to the findings that came out of the first round of key informant interviews that really did look at what happens with contraceptive service delivery programs in those transition phases across the preparedness to relief to recovery continuum. So looking not only at the onset of an emergency and what happens to a program in that moment, but also how programs transition as they move towards recovery in that setting. And something that was really consistently and strongly emphasized by both humanitarian and development respondents was that the baseline level of the system's strength, so thinking about health systems as well as preparedness, was highly predictive of the success of programming to adapt and to be sustainable. So for example, multiple respondents cited Bangladesh and the Rohingya response as being a really excellent example of a sustainable adaptive program. And they specifically cited the government's leadership and strong engagement, as well as the existence of national preparedness plans and activities. Whereas conversely, respondents spoke about more entrenched challenges in settings that face cyclical and protracted crises, where there may be weaker health systems or sort of vacuums in that area. So I think to what extent I could say that that would be predictive, I don't know. I don't know that our research necessarily reached the level of being able to be predictive per se, but that was really highly suggestive and really reflective of the importance of system strengthening and preparedness activities. The other piece, again, that came out of those first round of key informant interviews that I think speaks to this point was the importance of engaging with local partners and working together from the beginning of programming to ensure that programs were sustainable and would continue to function, and that local partners had the capacities and resources required to sustain and scale those programs, even when international organizations were no longer operating on the ground. So those were some key findings, I think, that came out of that component of the landscaping assessment that speak to that question.
Thanks, Lily. I'm going to ask one more question and then turn back over to the panelists to answer both the question that I just said and then I think what is a related one. We have a comment that says, Somalia has one of the worst reproductive health indicators, including family planning even before the crisis. Is there any data on the new innovative ways of undertaking the essential services in such an insecure context? So I might turn over to the two panelists to have the final words on both that question and the other question around what you think is most predictive of contraceptive continuity in emergencies. I think that they may be related. Abdikhani, would you like to start since the question is specific to Somalia?
Yeah, thank you very much. Yes, actually, I think Somalis have the worst reproductive indicators, though the Somali Health and Demographic Surveys that recently launched in this year have shown a small or slight improvement in some indicators, though others have worsened. But I think the innovative ways have, the data. Actually, Somalia now using DHI2, and though the farm planning, specifically farm planning indicators are not reported across the country, but at least is, in some states they are already reporting. So I think having Minister of Health having that centralized data collection tool, which is DHI tool that are owned by the Federal Minister of Health, that will help at least to better coordinate the health indicators. And now there is a lot of work have been that are already on process in coordinating and trying to harmonize the indicators and reporting tools across Somalia. Yes, one of the worst indicators and reported is the farm planning uptakes, which there's a lot of contradicting indicators in different sources. But at least there is some improvement in improving the harmonizing the tools and indicators that have been in place. And yes, absolutely. If you see the Somali Health Demographic Survey shows there is some improvement, and now the Federal Minister of Health are also leading to have state specific demographic surveys, health demographic surveys that already have been done in Somaliland, and that collection is now going in Puntland, so that to see state-wise as well as national-wise. I think that what can I say. Thank you very much.
Thank you. Thanks so much. Gitari, do you want to, would you like to comment one last time on those questions?
Sure, Sarah. And also point out that momentum, integrated health, the resilience is not working in Somalia, but you're working in South Sudan, and you have sort of similar, experiences. You're also working in some additional countries in Central and Western Africa. And a lot of the things, of course, are similar. Of course, I like right from the beginning, of course, being aware of the context does matter. And so that question about the baseline status of the health system, of course, is important. I may not have particular, scientific data to support that, but you also know that the strength of the system determines then how stable to remain even in the presence of shocks and stresses. So one of the things is also reminds us continuous engagement and advocacy for the governments themselves, or whoever the decision makers are in that country, to maintain a high presence of family planning and reproductive health. Because we see, like you said earlier, we do recognize that during a crisis, or whether it's humanitarian or a pandemic, it's really dependent on how it was before. And so making sure that it is much easier to discuss FPRH as an essential service to an audience that already does recognize that even prior to the shock or stress. So advocacy, I think, must be important. I think the other thing that, and Lily has brought this one quite well, is also the element of making sure that you are strengthening local capacity, local organization, and especially even community-based organizations where decisions are made. So in this system also, because we also do recognize that some of the things we can be able to relieve the burden of the health system by making sure that community level interventions, health promotion, and preventive interventions can be provided to minimize people needing, therapeutic services or other interventions. So that making sure that then we strengthen our community systems as much as possible. Where possible, provide community-based distribution of FP commodities. I think self-care, I don't want to go there again, but a DMPS I think is a wonderful opportunity. I think the other thing for us, one opportunity usually means is post-pregnancy family planning, whether it's postpartum or post-abortion, and making sure that those opportunities utilize them as much as possible. And also integrating our messaging with other sectors. It could be other elements of the health sector, but also sometimes outside the health sector, where the economic activities or whatever else that is happening, that we bringing people, women and men together, whether they are together or separate, but groupings, that gives us opportunities for a lot to discuss these other elements that may make people to decide to seek services that are related to FPRH. Over.
Thank you. Thanks so much. This has been a really rich Q&A and discussion. I really appreciate it, everyone. I know we do have some other questions, but I think we've hit time and we need to go out into our breakout rooms. Can we go to the next slide, please? So we will be going into 5 breakout groups. Some of them have been combined based on levels of interest and making sure that we have enough people within each group, as well as not too many in any group. So the 5 groups will be adolescents and other marginalized groups, quality of care with a focus on method mix as well as supplies, data collection and use, preparedness and localization, and family planning during the COVID era. So you'll have about an hour and 15 minutes in your small groups, and each group has a facilitator who will guide the conversation, as well as someone who will use Mural software, which is a whiteboard type software, to input comments in real time so that everything can be kind of recorded on the spot. So we hope you find it to be a useful way to develop recommendations. We'll be looking at gaps, solutions, and what we'd like different target audiences to do. So with that, I think we can go ahead and break out into our groups. All right, so we're going to go through some of the recommendations, and then we'll just have a few minutes for people to comment on them. And as always, you can also put comments into the chat box. We will be tracking those. So if you have thoughts that you would like to share on the recommendations that have been developed, please do go ahead and put them there as well. All right, so it looks like the adolescents and marginalized groups group has come up with several recommendations. I guess, I don't know if Anushka or Katie, if either of you would like to come off of mute to share this.
Sure, happy to, and others, please feel free to jump in. So I think this first point around social accountability, I think really relates to the third point too, and the second one as well. This, the biggest thing that we really want to get out of this is, really ensuring that adolescents and young people are involved in sort of along the project cycle as well as the humanitarian program cycle. So that family planning and SRH services and programming can really be responsive to their needs. Using social accountability tools like the ones listed here really help to bring young people along with providers and other community members together so that young people can define for themselves what they need and what they're looking for, can help follow up. We felt like, those sorts of tools need to be institutionalized, not just at the community level, but in collaboration with the government at, various different levels, including through the coordination mechanisms. We had some good discussion about using participatory methods to collect and share data. I think Anne from Guttmacher gave us a really good, thought about having vignettes from the perspective of young people to be able to actually appeal to government decision makers, donors, et cetera, to really, influence them and while being responsive to the needs of young people. We talked about social norms, values, and attitudes quite a lot. We had some really great development practitioners in our group. So, talking about learning from development settings and translating some of that into for humanitarian settings, engaging religious and traditional leaders. We didn't spend a ton of time on groups other than adolescents, except a little bit talking about the importance of mainstreaming inclusion tools and approaches, whether for people with disabilities or SOGI populations, into broader, health facility, MISP-related tools that we use systematically in humanitarian settings. I'll pause there.
Thanks, Anushka. Can we go to the next slide, Lily? You can keep going, Anushka. I think we'll go straight through it all because I think that'll work better.
Oh, gotcha. Okay. Yeah, and I think I covered some of this, so I won't go into too much detail, but, really one of the concrete actions I think is really about building the evidence base. As many of you know, we've been working on the Adolescent SRH and Emergencies toolkit that will be released tomorrow. And so, one thing that we've been talking about is having maybe a live set of resources that people can contribute to, so that we're, in addition to that toolkit, using and that as an opportunity to share new resources and tools, and also advocating with donors to actually build the evidence base for things like social norms related to adolescents in humanitarian contexts. I think we've talked mostly about these other topics, but really, one thing to highlight is really having young people and youth-led organizations, people with disabilities, groups that are led by affected populations actually leading and coming up with these solutions themselves. So ensuring that there's adequate resourcing, funding, decision-making power for them to do that. And one thing that we mentioned with COVID is really thinking about, self-care approaches to really build the community resilience of these various groups. Thank you.
Thanks so much, Anishka. If people have responses, again, please put them into the chat box, as I'm not sure we'll end up with time to do some big group discussion. Thanks so much. These are really robust. I love them. Okay, next slide. All right, FP during COVID. Lily, would you like to share a little bit back? Lily, would you like to share?
Apologies, I was having difficulty unmuting myself.
No
yes,
worries.
Absolutely. So our discussion around, what we really need to do to take forward some of the lessons learned and innovations and adaptations from COVID had a lot to do around institutionalization of these innovations. So ensuring that these things around task shifting and sharing, multi-month provision of supplies, and telemedicine are captured in protocols, both at the organizational level, as well as among governments and ministries to authorize those policies and determine protocols that would govern how they should be implemented and monitored. Another thing that we discussed was that there has been really, a huge amount of data collection has been happening across organizations, often internally. Over the course of conducting our key informant interviews, multiple respondents discussed really interesting and innovative, creative approaches to capturing their experiences. And we also discussed the importance of that information not only living internally, but also being shared externally and supporting other organizations to learn from and adapt or adopt solutions that were effective, but also that data is a really important advocacy tool. We discussed in our group that governments still are not adequately prioritizing SRH, particularly contraceptive services, and that rights-based advocacy still is not always what moves the needle. And so if we're able to provide the data about the efficacy, for example, of telemedicine, if we're able to provide data on the efficacy of task shifting and sharing for supporting wider availability of contraceptive services, that's going to be very motivating for stakeholders to expand and invest in those approaches. I'll also add that we did discuss at the same time that we also know what works for provision of contraceptive services at the basic level. We know that good quality care, availability of diverse methods, supply chain strengthening, all of that community sensitization drives contraceptive use. And we have to be mindful that even as we test and implement really innovative technology-based solutions, we have to bear in mind that not all individuals within communities and not all settings have equal access to this technology. And we have to be mindful not to leave those people behind. Other solutions that were identified that should be taken forward, participants discussed their organizations using health records and data to identify clients that were likely to be facing stockouts of their method and sending community health workers out to them proactively to ensure that they didn't experience a gap. And people also discussed really innovative approaches using Facebook, using WhatsApp, using the internet and social media to create forums where with information about available services, and where even providers could be available to interact with people to ask and answer questions, to reach people that are experiencing movement restrictions. Although, again, this was noted that adolescents may be more facile with technology as compared to other populations, and that there may be disparate access and familiarity with using those tools. And finally, the last thing that I'll say is something else that came up is in developing and using these technology-based tools, it's really critical to engage people with expertise in designing technology and designing platforms for people who speak different languages, for people who have different levels of literacy, and really working with affected populations and target populations from the ground up to design those tools to ensure that they're really well suited for and meet the needs of a given population.
Thank you. Thanks, Lily. Okay, great. Next slide. Megan or Sarah, would you like to share back? We only have, please keep your share back to about 2 minutes, so that all of the groups can get a little bit of time.
Sure, I can go. So we talked about data. We're talking about a variety of things, including data collection and use. We discussed the fact that health facility staff should be allocated adequate time for data collection activities. We thought it was very important that health workers were trained on how to collect and use data, and why accurate and timely data are important, and talked a bit about the systems needed to facilitate this. A topic that was discussed amply was the need for consistent and clear definitions for key SRH indicators, notably for family planning. And within that, the need for people to agree to what those indicators are more broadly, so that UN entities, NGOs, donors would be able to kind of rally around those same definitions. Along with definitions, the importance also of using standard disaggregating information. So if we're disaggregating by age, what should those age disaggregations look like in order to save time so that people aren't spending days disaggregating into multiple categories. And then the need for standardized tools to collect a range of common indicators. Next slide, please. We also spoke quite a bit about the issue around developing a strong evidence base for family planning in various stages of an emergency cycle, and a big element there was the use of implementation research, especially looking at how to best reach underserved populations. Within this, we thought it was really important to engage with implementation partners and others on the ground, especially local groups. And also within that, to make sure that capacity was being built in the area of research and data collection. Really trying to combine all of the research that's being done with practical skills training to build a broader cadre of people who can then go off and conduct their own research. We also talked about the importance of using a range of research methods and being open to different types of evidence. Not everything that's evidence is published in a peer-reviewed journal. So how can we make sure that lessons that are learned that don't show up in the Lancet are also being applied to the work that we do? Also, the usual publish what doesn't work, and don't be afraid to talk about failures.
Thank you.
Over to you. Thanks.
Thanks, Megan. I'm so pleased with how specific everyone's recommendations have gotten. Okay, next slide. Preparedness and localization. Before I hand it over to Lorelei and Ashley, I just want to make sure that everyone on the line knows that next week, there's a webinar coming up to launch a new toolkit, the Ready to Save Lives Toolkit, which is a preparedness toolkit for SRH and emergencies. And if you need to sign up for that, I'll ask Lorelei to put it in the chat box after she speaks, she or Ashley. So handing over to Lorelei and Ashley, please only speak for 2 minutes.
So Ashley, I'll do one, you do one. How's that?
I'm actually happy for you to just do the whole thing, because I really didn't facilitate, just for for everyone. I really just participated.
Okay.
And Lorelai was very great facilitator.
Okay, well, thank you. So I think that there were a lot of themes that we touched on in our conversation that overlap with the points raised by the adolescent group and some of the other points. So I'll just quickly, we thought that it was very important that investments are made in integrating family planning and SRH preparedness into government and organizational preparedness efforts, and that this needed to be a cross-sectoral response, that you can't just work with the health ministries. You also need to engage with the ministries of finance, ministries of security and protection, if you're going to have robust SRH response early in an emergency. That through preparedness, we gave ourselves the opportunity to identify and engage local groups in advance of an emergency. And this was felt to be important partly because it might take time to build trust so that people feel like they can be engaged meaningfully. Some of those local groups might need assistance in developing their organizational capacity to really feel like they are able to be at the table and have their voices heard and have their organizations survive a crisis situation. It's been many youth organizations and others have struggled with COVID. That clusters, health and others, could be involved in preparedness. And next slide. That funding may be required for involvement of local organizations in working groups to advance preparedness. There was a nice example given from Nigeria where funding is going to local organizations to be involved in preparedness processes directly from the Gates Foundation, and partnering them with more established organizations to build their capacity. That there was a discussion about supply-specific preparedness plans, and that some of the complexity of engaging in humanitarian preparedness and response may need to be simplified, or groups may need to be partnering with these local organizations to enable them to meaningfully participate and to have their voices heard. And yeah, I think some of these themes repeat themselves throughout our conversation. So I will just say that we kind of ended on a note that the COVID pandemic has really raised people's awareness about the lack of preparedness in many cases, and presents us an opportunity to maybe propose what Ashley was calling the preparedness New Deal as something to move forward. And I look forward to talking more at the release of the preparedness toolkit next Tuesday. Thank you.
Thank you, Lorelai. All right, in the quality of care group, we really focused on, I'm not going to go through all of our recommendations because it would take way too long and we only have a minute left, but we focused on increasing awareness of emergency contraception, improving providers' knowledge and training on implants, IUDs, and EC, and addressing misconceptions about those methods. We talked about how to improve client-centered counseling and how to address stockouts and supply chains. So including issues around low knowledge and skills on supply chain management, long-term reliance on the kits, and how we can ensure that the development sector considers preparedness from a supply chain perspective in the work that they do. So if anyone is interested in learning more about the recommendations from this group, you can follow up with us and I'd be happy to share them, but I don't want to go late. So can we go to the last slide? Yep. All right. So thank you to everyone for joining us today. From my perspective, this was a really robust discussion and I really appreciate everyone's participation, and especially the facilitators and the discussants who gave excellent remarks that made that really rounded out all of the presentations and helped helped us understand some of the challenges that are being faced in particular locations. So thank you very much. We will be developing an advocacy brief to summarize these recommendations that we came up with today. And that brief, once it's done, will be disseminated widely to donors, to implementing agencies, including all of you today. These slides will also be disseminated, and the pieces of this that were recorded, which were the full group sessions, will be available. So huge thanks to everyone. And thank you to Lily for all the work you've done on the research, and to Sarah Casey for the work that you did overseeing some of the research. We look forward to following up with all of you.